topic for today is ovulation induction and back to school days. Before we go to back to school days, small glimpses about what we do at Birla Fertility and IVF. We've got more than 6,000 people who have joined us across 33 countries. 6,000 people, 33 countries, 2 years is a huge number. It's all due to our blessings. I mean, it's a big family we have created. And as I always say, before I move ahead, blessings from Lord Ganesha. I'm going to talk to you about 𝐓𝐷𝐿𝐼. This is 𝐓𝐷𝐿𝐼's statue from Mumbai. And the number is already test 351. What an auspicious number when I start my talk for you today. And this talk is going to be in 2 parts. Today will be a small glimpse of, about ovulation induction. And the next class will be on the poor responders and the hyper responders and post criteria. That's going to be very, very exciting. We're just going to build up some background. So what do we do here? We not only learn, we not only do a lot of masti here, we eat some chocolates and have some sumptuous lunches with Pino organizes, and we do some masti like this. Just for from showing this. सब बच्चे लोग हैं हमारे साथ में. All become children here, and we play together. We do a lot of fun. We have multiple such things which we do here. I thought I must put it here to share this, all the alumni, the way we are having fun, and I can put an now spelling everything here. So they have to be stopped. They have to be stopped from being the masti. That's the way we work at Birla Fertility at a unit in Delhi. So, hi guys, I start my talk here and I'll keep saying hello to all of you. I can see a lot of you are here. And so why are we here? This is the main point. Why are we having this class? We know that the Waterloo of ours is ovulation induction. Looks very simple, but with the new guidelines coming up, that's becoming much more complicated. Can someone tell me how many eggs we can retrieve from a donor nowadays? Any number in your mind?
7.
Yeah. Initially they said we can do low stimulation, but now they've again come to 7x. This is what they are writing all the RTIs. I imagine a girl having AMH of 3 to 4 or 5, and we start stimulating her, and we need to stop at 7 to 10x. So how difficult it is. So initially we were never worried about giving the dosages, but now we have to look at what we are giving also, because it's not only the matter of money, it's a matter of the legal guidelines coming up. Before this, we never actually bothered about the topic much, but now we have to learn the play of all these. So we are here basically to learn nuances of ovulation induction. Today's topic is OI. Today's topic is OI and not any other type of ovulation induction. And how do they differ? I'm going to talk to you in some time. We'll talk about OI, that is ovulation induction, OI. Then we'll talk about what is SO, what is COH, look at some publications, and then go home with a nice take-home message. I believe that around 70 of you have joined us today, today's batch who are new. In case you don't have our coordinates, I'll give you the coordinates in the end. Please send up a WhatsApp message so that we can enroll you in the group, and then we send you some nice literature to read. Okay, so an icebreaker round. We always play a small icebreaker round before I go to science. Quickly, I will tell someone to count who is wearing maximum colors here. So I leave it to Sandhya. I can see Sandhya there. Sandhya, let's see the screen. I leave it on you. Put on your lights. Who's wearing the maximum colors? You have 2 minutes. Please put on your cameras. It's going to be big fun, and a nice gift awaits you. And we send you nice gifts very frequently. So Sandhya, you're there. Wave your hands.
Yes, I can see. Dr. Sandhya.
Yeah, I'm there, ma'am. I'm there. But I'm watching this in the phone, so I couldn't see everyone at a time. I have to scroll my screen.
Yeah, you scroll your screen. You have 2 minutes.
Tell us who's wearing maximum colors here. We are also trying to find. Last time I think Divya won the award. No, Divya was the one who. Is Divya there today? Divya won the prize last time.
Dr. Devya has joined.
Yes,
Yeah.
sir. Good evening,
Yeah.
sir.
I hope you're not wearing so many colors today also. So
I'm
anyone?
wearing 5.
So who's wearing maximum colors? I think they deserve a small box
Dr.
of
Hema, I
chocolates from
could
our
see.
side.
Dr. Hema. Okay. I'm
Dr.
also
Hema.
screen.
Yeah.
Dr.
Maximum
Hema.
colors. Who's wearing
ले जाओ,
maximum colors?
पापा को ले जाओ.
So Sandhya, have you scrolled? Are you done with the?
I'm still scrolling. So many people.
Yeah. 384 people.
Yeah, and many of them are switched off the videos. So
Good evening, sir.
Hi, good evening. Hi, Lisa, how are you?
I'm
So I
good,
think
sir.
great. So I'll give you some time. You can all pick up the maximum colors. You keep doing that, and I'll start with my talk. Fine.
okay.
So hi everyone again. So coming to the icebreaker round for the science. I think all of us. I should ask how many of us doesn't use clomiphene. There are very few people who don't use clomiphene. We all use clomiphene. How many of you don't use letrozole? That would be my query. I think all of you would be using letrozole also. And number is touching 383, 383, 384. Fantastic. How many of you would have failed a cancelled cycle? A large number of it. I have a delivery doctor entering the waiting room. Delivery doctor, I'm with the delivery doctor also. So multiple pregnancies are pretty common. It happened. A lot of us have got an ovarian hyperstimulation syndrome. We've been through it. So now, how do we manage whenever we get a young girl who has got subfertility or infertility? We have to give them some medication to make their eggs. And the whole process of giving them some medications to make them ovulate or super ovulate is called ovulation induction and multiple other connotations. So in a young girl, a normal young girl would normally will make one egg every cycle that is being made in vivo, which is being fertilized, and their couple is able to get a baby. But when we start doing somebody's treatment, we have to make the ovaries grow, or we follow the natural cycle. But nowadays we want to make the ovaries grow, and for that we have to give them some drugs to make the follicles in our ovaries, and they are called ovulogins. There can be oral ovulogins, or there can be some drugs which can be given in a form of some injectables. They are the ovarian stimulation drugs to give to the people. So gradually, as we moved away from a single egg or two, 3 eggs, nowadays we have gone to getting large number of eggs, because more the number of eggs which we get, more the chance that we'll have a better outcome. So we are moving towards, as we look at it, we are moving towards multiple oocyte. We get multiple oocytes, we get more chance of giving them the pregnancy. And as we are aware that to get one euploid embryo, we get we need how many M2 oocytes? Anyone? To get one euploid embryo, blast I'm talking about, how many eggs are required?
7 to 8. 13 to 15.
7 to 8.
7 to 8 for a young girl. 7 to 8 M2s are required to give her one euploid embryo. No, talking about a euploid embryo. We're not talking about, and I'm talking about live birth rate. It's a live birth rate, not getting a pregnancy. It's a live birth rate. So 7 eggs निकालने पे उसको एक pregnancy मिलता है. It's a live birth rate. So what do? We want to give something to her, and we want to give something in the refrigerator for the second child of us. Because IVF is an expensive treatment, so we want to give her a 1 or 2 FPT cycles, and that's the way we work. So we are over-stimulating her. Natural cycle, 1 egg is required, but we are trying to get more than 10 to 15 eggs so that we are able to help her later on also. So stimulation has become the cornerstone of any IVF or IUI. This is the basic take-home message we all have, and I'm going to work on this particular message. Now, moving ahead further, I'll be covering the talk in the following headings. We will talk about, can someone mute everyone? So we're talking about And these headings will be ovulation induction versus superovulation. This is very important. What is OI? What is FSO? This we have to understand. We'll talk a bit about reproductive endocrinology. We'll talk about ASHRAE guidelines, my favorite guidelines, and we'll talk about some papers from VSM. All those things will be sent to you right away. The moment the lecture is over, we'll send you these things, and they'll be reaching your mailbox within half an hour of the lecture getting over. We'll review some literature and then come to an answer. And this will be prelude to the lecture coming next 10 days. That is on a very important lecture on stratification of the treatment. Today we are just making up the basics, and next class will be actually on super ovulation, or how to handle subfertility, infertility in a hyper-responder, unexpected response, expected poor response. So those all will be covered for us last time. So this is what we have to know. Lovely guidelines. I know that a lot of you may not be having it in your mailbox. Will be reaching you by 10 o'clock. I'm sure of it. We're going to send it to you. All of you who have not joined the group till now, who are joining from Facebook or LinkedIn, can send us a WhatsApp message and we'll be taking you in. So what is OI? Ovulation induction. So we have crossed 400 now. Number is 404. Great. Fantastic. So what is ovulation induction? It is a pharmacological method, treatment of the anovulatory woman to induce ovulation. So what term comes here is that it is for the woman who have got an ovulation. She's not ovulating. The young girl, healthy young girl is not ovulating, and we want her to ovulate. We give her some drugs and they are called ovulation induction drugs. That's the way, the background we make. And the basic pretext of any ovulation in an anovulatory woman specifically is doing ovulation induction, because we want a monofollicular growth. So this is what you have to understand. See, as we are advancing now, I remember the batches which I had initially. What type of shadow is this? So it's a black shadow, white shadow. So gradually, as we are evolving, the type of shadows have become hyperechoic, isoechoic, mixed echogenicity. We talk about white lines. We talk about some floaters, echoes. That's the way we have moving away with the. So the point remains that same way we have to understand what is OI and what is SO. So the OI term, when it comes, it means that we are looking at the monofollicular growth and ovulation in an anovulatory woman. That's the way we define this. And if you look at WHO criteria, WHO has got 5 types of anovulation. Type 1 is hypo. Type 2 is PCO. So we're going to talk about type 2 women. We have to know these terminologies. As we are evolving, we are becoming better. We have already taken over G20 also. So our country is going up and up. So we have to know about these things. So we have to know that there are 5 types of anovulation. And when we handle type 2 anovulation with hoping for an monofollicular growth, that is called ovarian induction, or we call it OI. But not necessary. We can also use OI for male factor, age-related or unexplained infertility. But the aim here is to get a monofollicular. But remember, whatever we use for this monofollicular growth, whatever we use, there is a possibility that in case we use that drug in a bigger dose, that can lead to multifollicular growth. So now looking at letrozole. Letrozole is a very mild drug. Clomiphene, a very mild drug. But very frequently, you may find a young boy and a girl who comes to us, we give them letrozole in a high dose or clomiphene in a high dose, that may lead to very bad ovarian hyperstimulation. So it's like a knife. We can use knife to eat our breakfast, and we can use a knife to injure somebody. So When talk about OI, ovulation induction, we use our knife to get a single healthy egg from the ovary, and that is called ovarian induction or ovulation induction. In case we use it in very high dosages, that can lead to ovarian hyperstimulation also. Nowadays, a lot of people are using, they use letrozole, clomiphene for IVF also. So I think we can talk about it next class when time comes. So there are 3 more terms. I just spoke about a term called OI. We talk about a term called OI, that is ovulation induction. And now we go to these 3 terms. You have to know about these things, because times are changing and we can't, jaise the waise chal nahi sakta hai. That's the reason of bringing the whole thing in front of you. So we have OI on one side, monofollicular growth, and then on the other side, we want to give somebody a multifollicular growth. So when we aim for a multifollicular growth, we call that term superovulation, controlled ovarian hyperstimulation, or we call it OS. That this means ovarian hyperstimulation or ovarian stimulation. Whenever we get an OS, SO, COH, it means that we are going in for multifollicular growth. And multiple follicular growth is primarily for IVF, never for IUI. For IUI, we don't do any activity. This is what we have to know. So what all can we use? What all can we use to generate eggs from a woman? We carry out ovarian stimulation or ovarian induction. We can use either oral drugs. So they are like tamoxifen, clomiphene, letrozole, anastrozole, all can be used. And on the other side, but these will all somehow lead to ovulation induction. But in case we misuse them, they can lead to ovarian hyperstimulation also. But on the other side, gentlemen, ladies, when we use gonadotropins, we are aiming for multifollicular growth. This is first message I want to leave for all. First message. Good. So let me admit Dr. Anil and moving ahead. So when you look at the ovarian stimulation protocols, they can be we can use either clomiphene, we can use clomiphene, we can use letrozole, gonadotropins, then we can give them in combination. We can combine these many drugs, multiple ways, GnRH, analogs, antagonists, so multiple things are there. We have some soft protocols, we call them minimal stimulation protocols, where we combine clomiphene, letrozole with HMGs. So the endpoint is that we want to give them a very soft protocol and yet get few number of eggs and patient can save some money. They're called minimal stimulation protocols. But all of them are part of super ovulation and not OI. So why is it so important? Because we know that one size does not fit all. Everyone requires a different sort of a protocol, and all the protocols are nowadays stratified. So stratification of a protocol to suit a particular person is called, that's the criteria we follow, which is called a Poseidon criteria. So the background is that we can't give the same protocol to all. We keep tweaking our protocols. And for this, we have to know what is an optimal ovarian stimulation. Optimal kya hota hai? Optimal means that we should not have understimulation. Optimal means that we should not have understimulation. This is very important. It means that we have to avoid overstimulation. It means that we have to minimize cycle cancellation. It means that we should try to avoid ovarian hyperstimulation and reduce premature LH surge. So whenever we are working with any patient, our biggest enemy is premature LH surge. That should not come. We are always fighting for reducing the premature LH surge. The biggest enemy we have, and all our protocols are designed along with this. And as we superovulate, as we give them more stimulation, it's a more chance of premature LH surge coming. With a monofollicular growth, it doesn't come that easily, but with a multiple stimulations, it occurs very commonly. So we commonly ask questions are when to stimulate IUI or IVF cycle, which protocol to use. Which protocol to use is very, very important for us. And then we know how much is our protocol costing. So we know that a set of A set of letrozole tablets, they cost us rupees 300. A clomiphene will cost around 150 or 200. So we have to know which protocol to use, how much it will cost us, how do we work up a patient, how do we manage an anovulatory woman, how do we manage a hyporesponder or a hyperresponder, when to add gonadotropins, and what would be the outcome. So these are all the things which we keep in our mind and then take the call. So in case we are going in for a patient with for IUI, we want to give her monofollicular growth and we use OI, but when we shift towards an IVF cycle, we have to give a controlled ovarian hyperstimulation. These are all things we have to know when we start the case. But remember, the endpoint here will be the live birth rate. A live birth rate, clinical pregnancy rate, abortions, OHSS, and multiple pregnancy rate. So gone are the days when we spoke about beta-CG rate. So beta-CG rate is now no longer being considered, though it is the KPI for us, but we are looking at live birth rate. Clinical live birth rate, and we write as CLBR. So 7 oocytes will lead to 1 CLBR. This is what the way we look at it. So what are the predictors for good outcome? For ovulation induction, good endometrium, because we're going to do her IUI for her, good endometrium, or maybe if we want to do a natural cycle IVF for her, that's absolutely good. Or we are aiming for a monofollicular growth, that's important, and we need to have moderate levels of E2. More the number of follicles, more would be the E2. More the number of follicles, more would be the LH. As I've told you, for all the friends who are there, from our alumni, we know that E2 is directly proportional to LH, and when E2 will rise, LH will rise. And both are very, very derogatory for an optimal outcome in the pregnancy. For the pregnancy, when E2 goes high, it is bad. And when E2 goes high, LH goes very high. And when LH goes very high, we have VGF going very high. And when VGF is going high, along with this, we'll have PFR going high, and we'll also have a rise in the androgens. A typical scenario of a PCO patient. These are all things we have to avoid. We have very clear beliefs. जितने ज़्यादा egg निकलेंगे उतना अच्छा है हमारे लिए. So more the merrier. This is one myth we have in our mind, and this myth has to now be we have to trash it. Mild stimulation gives you better quality. This is coming up everywhere. So, but we have been trying to do larger stimulation because we want to generate more number of embryos. We can do some embryo donation, sharings. So those things have to end now. But normally 8 to 17 eggs are the ones which are good. So this is the metaphase 2. Because they can get around 8 to 15 M2s, they are good. We need eggs. We need eggs, but we don't need all the eggs. This is what we have to know. In case her AFC is 20, don't trouble her and try to meet the targets of getting 20 oocytes from. That's the way. I'm going to talk to you in the next class about FORT and talk to you about FOI. They are basically for step ahead from OI. When we talk about COH, we talk about FORT and FOI. FORT is follicular output rate, and FOI is follicle to oocyte index. So this will come very handy, these two terms, when we go to hyper and hyperresponders in IVF. Now we have got a lot of burning issues. We want to do some stimulation. Which medication will give us a better outcome? That's number one. Which product is better? FSH, urinary, recombinant, highly purified. Some gives you HD, some give you XP. You don't know what to do. Actually, you're confused. FSH levels are low or high. What type of drug to use? How much letrozole to be given? How much clomiphene to be given? And final oocyte maturation with urinary, recombinant, what type of trigger to be given? Management of high and poor responders, they all become part of ovarian stimulation. Let's look at a normal ovulatory cycle. Let's see what happens in a normal ovulatory cycle. We find that in a normal ovulatory cycle, on day 2, assume this is a day 2 for this woman. On day 2, her E2 will be low. This we all know. When E2 is low, her FSH will be going high. So she'll have FSH values going high, and then FSH goes high, then the follicle will mature and become around 20 millimeter or 2 centimeter. And as they become high, that's the time levels of E2, as you can see here, E2 will go high. When E2 goes high, E2 will suppress FSH. That's the formula number 1 is that E2 is inversely proportional. When one of them is low, other one will rise. That's the way they work. So on day 2, the levels of E2 are high, FSH increases, and when E2 goes very high, FSH is, and when FSH is going down, E2 going high, we'll have a surge in the LH. As you can see here, the LH surge will occur because LH surge follows E2, and when LH goes very high, LH will get in progesterone. You'll find that progesterone follows LH, and then when LH is rising, we get one more gentle peak of E2. E2 also rises. That's the time when we have formation of corpus luteum, and in case there is no pregnancy, we'll end up with the same scenario which was here. And as you say in the army, jaise the. It's going to come back again. The cycle starts in case there is no fertilization. A small glimpse about what all happens, a small picture again, just to get you into this, because without understanding this, you won't be able to understand the pathophysiology. In a PCO patient, when we talk about, she'll have multiple follicles here in a PCO patient, and this girl will always have high levels of E2 on day 2. So PCO patients will have multiple follicles and E2 will be high. In a normal responsive patient, they will have a low levels of E2 because they've got a single follicle or less number of follicles. So when E2 goes high in a PCO patient, will find that their FSH will be always low. E2 is high and LH is high. This happens in a PCO patient, typically in a PCO patients. So, but in other people, when the start of cycles start, they will have a rise in the levels of E2. E2 goes high, LH goes high. E2 high, LH high. So these three are friends. Just remember that E2, LH, and progesterone are good friends. They all come together. And then when the LH has played the role, LH will come down, and then in the end we'll have rise of estrogen also. And then in case there is pregnancy occurring at this point of time, it will take off. Values will keep going high, otherwise they will fall down, and the whole cycle starts again. Another big concept you have to all know, because you're going to talk about clomiphene and letrozole, is that what part of a cell does what. So we have an OCC complex. We have an OCC complex here. It's got two layers. It's got an outer layer which is called a granulosa cell layer. We can see this in yellow. And inside we got the theca cell compartment. And you find that we have, here we have the theca cell compartment which is yellow, and the brown one is the granulosa cell layer. There are two different compartments, absolutely two different compartments, like in the male. So first of all, what happens is that FSH will act upon the granulosa cells and make aromatase. It makes aromatase, and on the other hand, the LH will act upon the theca cells to make androgens. Now these androgens are converted by this aromatase into estrogen. This is what is a normal way the girl makes E2. Any woman makes an E2. That's the principle it follows, and for its forming E2 is very important to have aromatase. Whenever E2 is high, aromatase is high. This is a message I want to leave to you. You can say that E2 values, they depend upon aromatase. The take-home message. I'm very fond of giving you such small proportional signs. E2 is high, aromatase is high. Aromatase is high, E2 is high. Aromatase is high, E2 high, LH is high. LH high, aromatase high, E2 high, VGF is high, progesterone is high. So what do we get? क्या होता है? Chaos, total chaos. Nothing happens here. So we have to break this nexus and see to it that we work in the right proportions. So we are looking at this number and we find that the game changer in the whole of reproductive endocrinology is not E2LH, it is aromatase. So never underestimate aromatase. Okay, now looking at what happens in the normal cycle, we'll talk about the normal cycle in the woman. We'll find that in the woman, the normal cycle occurs, she'll have a small follicle on which will have low E2, where E2 will be low. E2 is low on day 2. This is day 2. FSH will come. FSH will act upon the follicle and make the follicle big to around 2 centimeter. And then it will make around 200 picograms of E2, a mature follicle. And that's the time E2 will go high. So E2 at the beginning of the cycle, when the cycle is starting, the E2 is around 30 to 35 or 40, not more than that in a healthy woman. But as the follicle matures, the E2 values are going to touch 200. So E2 grows from 40 to 200 approximately. This means that E2, this one, E2 is how many X? 4X, 4 times or 5 times. E2 is around 5 times. E2 occurs at the surge of E2. So E2 is 5X. Can someone tell me how much is LH? LH can be 10 to 20X. 20X.
It will be 20 times, sir.
20 times. That's what I'm saying. It's 10 to 20. I just wanted to bring your thought process to something more. एक जमाना था when we spoke about clomiphene, letrozole, 2 गोली खा लो, 1 गोली खा लो. But all those days are gone. We guys are evolving and we are the best in the world. So you must talk in terms of the curves. How do things go wrong? And this is our endeavor to understand things in a very formal way. So what happens? When एक फंडा याद रखो that E2 is inversely proportional to FSH. बाकी सारी की सारी आर्मी एक तरफ है और FSH एक तरफ. This you have to remember. FSH is the one poor guy standing in one corner and rest all are together. I hope you'll remember it. In our batches, we talk around 6 hours on this particular topic. So when FSH is low, when the E2 is low, FSH rises. When FSH rises, E2 becomes high. When E2 rises, it will suppress FSH. So what happens? In the beginning, we have around 7 to 8 AFC. 7 to 8 AFC is there. And the E2 is low. So one of them, who is the healthiest, will respond more to the FSH. And forming E2. It starts forming E2. And as the E2 goes high, what's going to happen is that E2 will suppress FSH. As a result, out of all those follicles which are there, one will mature and rest all will undergo atresia. That's the basic concept, basic funda of any monofollicular growth which occurs in our body without our knowing. This is occurring in our body. Every month is occurring in our body and we don't actually know about it. Coming to a PCO patient. PCO, what happens? On day 2, follicles are very high. Now, each follicle, can someone tell me what is an average E2 on day 2 of the cycle? Any one of you?
50, less than 40, 45 to 50, less than 50. 40 picograms.
Fantastic. All of you are
30 to 40 picograms.
I was talking to the batch today also that why our gynecology is so brilliant. Asking the batch today, as I asked, is there anyone in the world, is there anyone amongst you, amongst 413, 15 people who has not used letrozole? Any one of you could not use the letrozole? No, Dr. Ranjit is laughing at my question. Has anyone who's not used clomiphene? Dr. Shekhar is thinking something. He's going to tell me something. Actually, all I've used. Is there any gynecologist who has not won a gold medal? Is there any gynecologist who has not won the gold medal? Every gynecologist is a gold medal winner. I am also sometime with you. Shekhar is with me. We are all nalak bache. Dr. Das है ना हमारे साथ में आज. Dr. Das is there. Dr. Das सबके gold medal चोरी कर लेती है. She's got a bag of gold medals with her. Okay, so just getting some fun for you guys. So just know that on day 2, so you guys are brilliant, just brilliant. You win all the gold. You deserve all the gold medals. So on day 2, when we have, say, in a PCO patient, we have got, say, 20 AFC, and each is secreting how much? They are secreting around 30 to 40 E2 picograms. You can imagine how high will be the E2 in this one. But E2 is pretty high, and when the E2 goes high, this E2 will suppress FSH, and E2 will bring premature surge of LH. When FSH is not there, can any follicle be stimulated? Not stimulated. So any young girl, or all the girls are young till 42, 43, anovulation. Anovulation occurs. The PCOs are known to have anovulation due to low FSH on day 2. This is what you have to know. And this is one good funda I wanted to leave with you. So PCOs are known to have on day 2 low FSH, high LH, high E2, and premature surges of progesterone. So as a result, the girl will never ovulate. And here comes the importance of using aromatase inhibitor. When E2 is high, what is high? Can someone tell me? When E2 is high, what has to be high?
Aromatase.
Fantastic. So
Aromatase is high.
to kill E2, what do we use? Fantastic. We have given the answer. Very simple answer you have given to me. Very good. But remember it. Remember that answer also. Remember that answer also. The store of antral follicles in the ovary. Now, we are very commonly, is there anyone who has not used DHE or Ovaries Plus? Any one of you? I think every woman is taking DHEA. Every woman is taking some Conceive. Keep writing such drugs for the people. So, we know that we have a limited number of eggs in the woman, follicles in the woman, and we're always finding new methods of getting more number of eggs from this woman, because getting few oocytes is not a good thing. And this I'll be dealing for you at great length in 1.5 hours in the post-treatment criteria next month. So we are always trying to find out what to do for OI in a woman who has got low ovarian reserve. What to give? Will Ovaries Plus will work? Ovaries will work. Should we add melatonin, or we give DHEA? Should we give SR? What dose we give? We're talking about it. Yes, fantastic. So now coming to the basics of ovulation. FSH elevation. सबसे पहले FSH को तो आना ही है. Till the time we won't have FSH, nothing is going to happen. E2 has to fall down and FSH has to come. This is a basic concept. So FSH elevation is the most important thing which is required for a woman to form an egg, form a follicle. Normal FSH levels are around 4 to 5. But when a girl has to ovulate, levels of FSH has to go high. So like we have to push the ovary to make an egg. At the level of 4 to 5, 5.5, 6 of FSH, ovary can't be pushed. So we need a small surge of FSH. When FSH surge comes, FSH will act upon the nerve cell layer and start making aromatase. That's the way it works. So FSH has to go against a threshold. A threshold has to be there to go above. Only then ovary will be stimulated. And that surge is not only above the threshold level, but FSH window. FSH window also. So just remember that there is something called an FSH window which is important, and the threshold. So first of all, FSH has to go high, and then FSH will fall down. So we'll get a monofollicular. But in case FSH goes high, so in case we have 8-10x here, it goes high and comes down, we'll have one follicular growth. If it goes and maintains high levels, then we'll have multiple. That's the way it works. So clomiphene, we can do IVF with clomiphene. We can do IVF with letrozole, but increasing them for 8 to 10 days. But where to use what? Now, suppose we are doing IVF for the patient and she's a poor responder. She's a poor responder. Then we don't use letrozole. Then we use clomiphene only. A few tricks and tips I'll give you the next class. So what to use, where to use clomiphene, where to use letrozole is important. But remember that in case you give a simple drug above the threshold or increase the threshold for longer time, a simple IUI cycle can be converted into a multifollicular growth for IVF. That's the way we are using it also. So when the levels of FSH surpass a certain threshold value, एक certain threshold value जब cross किया FSH ने तो वो काम करना शुरू करेगा. That's the time when oocyte follicle will be acted upon that, and then it will lead to expansion of the granulosa cell layer and the fluid volume will increase, and that's the time aromatase will start. But provided, gentlemen, ladies, threshold cross किया और threshold से गिर गए, तो क्लोमिफेन खिलाओ 5 दिन के लिए, लेट्रोजोल खिलाओ 5 दिन के लिए 2.5 मिलीग्राम, क्रॉस किया गिर गया. But you start pumping clomiphene like a Marie biscuit. In the morning you get up and with a cup of tea you take a Marie biscuit and you also take 1 tablet of clomiphene. What will happen? Threshold cross किया और चलता रहा. You'll have multifollicular. So the aim is that you generate one curve. That curve goes high, generate some E2 in this 2-3 days, and then it will fall down. So FSH values have to fall down as E2 is rising. Okay. So we, how do we check? How do we look at the FSH exposure? How do we do it? We give somebody HMG, we give somebody FSH, we give them urinary, recombinant, highly purified, XP, HD, and multiple things. Bhara pada pura market, and everyone is better than another. From different brands are making different FSH combinations, but the overall, they say all the brands are good enough. Some people use recombinant, some people use urinary. I leave it on that. Apart from administering FSH as an exogenous drug, we can give somebody some other drug like clomiphene and letrozole, and they can also lead to prolonged FSH exposure, because clomiphene and letrozole will also increase FSH exposure, like tamoxifen also. So we have to know that not only by giving it from outside, but giving it endogenous, by giving them oral tablets, they can also work like FSH enhancers. So oocyte numbers and dosages, what is the relation like? Now we know that number of oocytes in a woman at 40 are around 8,000, at 35 are around 35,000, and at around 18 or 19 around 2.5 lakhs. This is the number which we have in our. And as the woman will age, the levels of FSH, the levels of the number of oocytes is gonna fall down. At 50, 1,000, 40, 8,000, 35 years, 35,000, 18 years, 2.5 lakhs. At birth, 3 million. At 20 weeks, 6 million. Just remember these numbers. So numbers are falling down. A woman doesn't have the choice of compounding her number, and they start falling very frequently. The fall can be around 12% after 35 years of age per year. The way the levels of AMH will, the levels of AFC will fall down. Just remember that we keep visiting multiple units. I went to one unit out of our country. I found that their starting dose was 450 units of FSH. 450 units. I still find a lot of our friends, they are उनके हाथ वीक करते रहते हैं. जहां मौका लगता है 450, 600, 700, it's still happening. I'm amazed why it is happening. So this is the reason that this topic is very dear to my heart. I've talked to so many. I'm so happy that you 415 of you are here, and you should know that we should learn that we should never overstimulate. It won't work. अब मुझे खाना खाना है, मुझे भूख लगी है. I want to have a pizza. How much pizza can I eat? I can eat half a pizza, full pizza, depending on what pizza size is there. In case you give me 10 pizzas, can I eat 10 pizzas? Will it benefit me? It won't benefit me. So for any young woman, the dose should not cross 300 units of HMG. This is very, very clear. The minimal dose required to give her some outcome in a normal responder is 50 units. Is 50 units. 50. आने के साथ she will start responding, and minimal response, and to get maximum response 220. 300 is not recommended now. 300 we still gave, upper limit is 300, but we should start with 50 is to make them respond, but an ideal dose is around 225. So we have multiple titration that we'll talk about in the next class, next week probably. So optimal dose is between 150 to 225 in a standard patient. So don't start with 300, 450, 750, 650. You have the power of prescribing, and patient has got power to pay. Don't do this. So look at it. It all depends upon the level of AMH. AMH levels are high, we give a softer dose. When AMH levels are low, we give higher dose. But overall, I say 250 mat cross karo. Don't cross 225 to start with. Normally with AMH of more than 3, start with 150. AMH of more than 6, we start with 75, maybe 37.5. Because we want to give them a softer product. So 150 is good enough for an PCO patient. Don't go to 225s and 300. Somehow we feel very jittery. 4 दिन लगाया, and then our hands start shaking. बढ़ा दो, 50 बढ़ा दो, 100 बढ़ा दो. That won't do any good. It only cause problem with them. And we are more is better and less is better. This is the wrong concept. These are the various factors we have. And in case I have to pick up for OI any of these factors, I'll pick up age, I'll pick up AFC. These are my 2 favorite things. They come very cheap. FSH, never. AMH, yes, when you want to do any controlled ovarian hyperstimulation, but not for OI. So AMH, yes, you can use, but not in every patient. Inhibin B and estradiol, never. Just the guidelines we have. So in case we have an option, I like to go in for age and AFC. They corroborate quite well. Patient has got money, or you want to do some stimulation, then AMH can come into play, but FSH, no. This is what I want to tell you people. The PC ovary and the poor responder ovary. Now coming to some important things. Whenever E2 is rising, what rises with E2? Anyone? I've just told you when
LH.
LH. So the whole of fight is about reducing the LH. अब LH ऐसा तो any घोड़ा किसी को पकड़ के रख लिया. We can't go and hold that horse कि तो आगे नहीं बढ़ेगा. When E2 is going on the piggy riding on the horse, LH is increasing. And LH is one thing. And what does LH do? Anyone of our alumnus or anyone. What is the main role of LH, sir?
Progesterone is
Maturation of the granular cells.
Progesterone.
Ovulation. Ovulation of the
Luteinization.
Vascular endothelial growth factor बढ़ाता है.
Vegetable endothelial growth factor.
Vascular endothelial growth factor.
Premature ovulation.
Fertilization.
Oocyte inhibitor करेगा. Oocyte inhibitor factor.
याद गए थे सब मेरे तुक्के याद गए और मैं पेरेंट्स से देख लूँ.
Luteinization.
The blood flow.
acts on the blood vessels.
Final maturation of the oocyte.
Where am I? Who said maturation inhibitor? This is the thing. When
Sir, me, Dr. Archana.
जीत गई अर्चना. Okay, good.
Dr.
I have told everyone in our academy, we have got a very clear funda. Any parent who won't talk, that parent will reach where?
Antagonist.
No.
Will be cooked.
Any non-talking parrot will reach where?
Will get roasted, sir.
Roasted.
Roasted. Barbecue. You keep talking, guys. Keep talking. That's the way our family works.
What is the answer?
OMI.
Oocyte maturation.
Causes oocyte maturation.
This is the main thing. That's the main role of LH. LH का main role ये है. अगर ये नहीं है तो बाकी सब everything is secondary. So when stimulating the ovaries to create multifollicular development, LH untimely is the problem. And then we have to, in case LH comes and we don't suppress the LH, then LH will prematurely advance the maturity of the immature follicles. And then the follicles will mature very quickly and the egg is not ready for nuclear maturity. Cytoplasm is not ready. As a result, the eggs are of a poor quality. Just remember that OMI is important, but to control them, we use GnRH agonists, we use antagonists, and we are also doing PPOS. We will give the people some drugs like dofestrone or MPA, Maprate, all these things we give to the people. Fine. So oocytes and then.
Sir, LH will suppress OMI.
Yeah. Because oocyte maturation inhibitor is not allowing the oocyte to mature. वो रोक रहा है mature होने से. जब LH आएगा तो रोकना बंद कर देगा. And there will be premature maturity of an oocyte, which you want to avoid.
Thank you.
हम रोक रहे हैं ना उसकी maturity. रोक रहा है. Oocyte maturation inhibitor is not allowing the oocyte to mature. And we don't want oocyte to mature. In case we give LH, oocytes will start maturing. So we find in PCO patients, oocytes are not of good quality because they get prematurely activated. That's the point.
Okay.
So to know, again, LH will also affect the endometrium because LH will bring what? P4. And this will bring secretory changes in the endometrium. So LH peak is not a good one to have, and LH peak has to be suppressed. Time comes, we have to increase the LH. Otherwise, you have to keep the LH low. This we have to know. And to keep the LH low, we have to use GnRH agonist or antagonist. Fantastic. This is all theory part. So we have to know that we can give somebody an LH by giving her an HCG or by giving her agonist.
Agonist trigger.
Agonist trigger. When we give an agonist trigger, to will act upon the hypothalamus pituitary and bring out LH. Or we can give her surrogate LH in the form of HCG. So this is all I want to tell in such a big class. I won't go to more bigger details as we talk. Otherwise, FSH window threshold is important. Levels of FSH has to go high. It goes high, no, it's going to work. In case at a lower level, the follicle won't respond. So this is a follicle lying here. FSH level still here won't work. So FSH has to go and touch it. Threshold has to go high. Cross it. And once crosses, then it should come down very immediately. Otherwise, more number of follicles are recruited. So for a monofollicular growth, we need a single follicle. So what we do is, when we have a low follicular growth, we'll always have one odd follicle. Low FSH, we'll have one odd follicle growing. So what we're doing here is that we are having a threshold concentration and a window concentration. In case we cross this, what will happen? We'll have large number of follicles growing. When we have a low concentration, like here, as we find here, then we have a monofollicular growth. So this is a better picture. Look at this picture without wasting much of time. We have multiple follicles here. AFCs are here. Pretty good. She's a good girl with good ovaries. And we have the plain simple 3 to 4 days window period of FSH. FSH comes, makes one follicle, and then levels of FSH will go down, and all other follicles which are chasing it will fall down. Only one good follicle will grow. That's the beauty of FSH, threshold and window in vivo. But now what we do is, we want to do something more. So we increase this window from here to this. हमने window बढ़ा दी. Window खोल दिया हमने. Threshold cross किया और window को खोल दिया by giving either prolonged clomiphene, prolonged letrozole, or by giving her exogenous FSH in terms of HMG or FSH on daily doses. What will happen? One follicle is selected, and then other follicles will also follow, and will have multiple follicles. That's the way these follicles, they start growing and maturing. Giving exogenous FSH will lead to what? Exogenous FSH will normally will make one follicle, and then it will go quiet. Other follicles will become atretic. But here, one follicle maturing, it will give rise to E2. E2 will tell the hypothalamus, shut up, don't give me FSH. Hypothalamus will take the shut up call. No FSH. But we are giving her injections from outside. So we have cut off hypothalamus pituitary axis, and we are giving exogenous FSH. As a result, multiple follicles. That's the beauty of an exogenous follicular growth, because threshold cross kiya, or bahar se every day we give her a shot of 225, 150 of FSH, and she'll have multiple follicular growth. Small thing about clomiphene citrate, how does it work? When we talk about OI, we're talking about, gentlemen, ladies, about clomiphene citrate. Simple clomiphene citrate. 55 years we are using it, we know it. Pregnancy rate 10 to 20%. Ovulation will occur in around 85% of cases. We know about clomiphene citrate, wonderful drug. Look here. When we give somebody clomiphene, clomiphene will bind upon the hypothalamus pituitary axis, and it will deplete receptor concentrations. So when we give somebody clomiphene, receptors of estrogen are, when estrogen comes, the hypothalamus can't get negative inhibition because receptors are choked in the mind. The pituitary axis is choked with the receptors due to clomiphene acting there. As a result, negative E2 doesn't work here, and FSH keeps coming down, and then we tend to get multiple follicles. That's the main problem with clomiphene. Clomiphene, in the prolonged action of 7 to 8 days, it will bind upon the receptors in the hypothalamus pituitary area, and when the follicle is growing and trying to suppress FSH, it doesn't go and hit here because it's already occupied. Look-alike molecules are there, and as a result, we start getting more FSH, and we get multiple follicular growth is happening. Clomiphene has got an anti-estrogenic effect. That's all I want to tell you here. Rest you all know. The topic is about OI, so I'll focus more on OI and letrozole. How does letrozole work? The third generation aromatic inhibitor came to us in 2001. Clomiphene came around 55, 60 years back. This came only 22 years back. And out of this 22 years, for 4 or 5 years, it was banned also, letrozole. Letrozole के multiple protocols होते हैं. You know about, we have already had a curtain raiser on letrozole protocols. Very good class we had for 2 hours. Letrozole in a small dose will give you monofollicular growth. Once you make it higher dosages, they will lead to multifollicular growth. That's the way the letrozole works. And then moving ahead, letrozole works for only 2 days. Clomiphene for around 7 days. As a result, letrozole will give you monofollicular growth because the half-life is 45 hours and clomiphene is around 1 week. As a result, we have better outcome in a letrozole cycle in a low dose. In case we give letrozole in a dose of 5 milligram for 10 days, it will create havoc. You can do IVF thereafter. How does letrozole work? We know it. Letrozole will block, it will act upon at the level of, it will block aromatase, as you can see here, it will block here. It will block aromatase. When aromatase is blocked, then levels of E2 will fall down. When E2 falls down, FSH will rise. And FSH rising will lead to a single follicular growth. FSH goes high, And because letrozole is working only for 45 hours, just a half-life. So letrozole goes high, letrozole we are giving, FSH goes high, and FSH will start recruiting the follicles. One follicle is recruited, but by that time, letrozole stops working. So E2 ka inhibition chala jata hai, and we tend to get monofollicular to become atretic. So this is the simple chart where you look at that letrozole will always lead to a monofollicular growth, and clomiphene will always have a multifollicular. This is what we all are supposed to know. And this we have, and it's primarily due to long half-life of clomiphene citrate. Clomiphene citrate will work for 7 days, and letrozole will work for 45 hours. So letrozole will give you monofollicular growth, and clomiphene will give you multifollicular. Now, in the last 5 minutes, this all prelude to the next lecture of 1.5 hours, which we're going to take a long lecture. It's about list of recommendations from ESHRE. There are 6 different chapters I have just covered for you, summarized for you. The first chapter, as you can see here, this chapter talks about the pre-stimulation management. When we are doing pre-stimulation management, what do we do? Second is, how do we suppress LH? That is number 2. Third is, what adjuvants they work? Fourth is there any non-conventional stimulation method? 5 is the monitoring. 6 is the trigger. So these are very important for us to know how all these drugs they work. Pre-stimulation management, simple. Don't apply your mind. These are the hard facts you have to know. That in case we have an option, we should be following AFC. Because AFC is cheap. AFC is free of cost. AMH is an expensive one. But we can do either AFC or AMH. Both are okay. Given an option, I prefer the AFC for monofollicular. For multiple follicular growth, okay, AMH is okay. This is what we have to do. Don't do any other testings. Some people are very fond of, maybe I'm very fond of giving pills before their IVF cycle. मुझे बड़ा शौक है. Overall लिख दिया, ये लिख दिया, वो लिख के दिया. Never write. These drugs are not recommended. Before any NTAG cycle, you want to make batches, you may give it in a long protocol. But in an AP protocol, antagonist protocol, we don't give any pre-treatment COC. This you have to remember. The ESHRE guidelines, they're not my guidelines. Many people are fond of doing P4, E2s, दुनिया भर के टेस्ट कर डालते हैं. In MNB, कुछ भी नहीं करना है. Day 2 of cycle, nothing to be done. P4, never to be done. LH, never to be done. There are few indications, but they are for frozen embryo transfer, not for a routine. Or when we are doing long protocol, we are down-regulating, we'll look for down-regulating. But in AP protocol, don't do anything.
So what is the reason that we don't give OCPs in ANTAG protocol? What is it?
I'll just come to this. Let me finish off this thought process and I'll come to this. Let me finish this thought process. So when we come to the LH suppression, how do we go to LH suppression? In LH suppression, what we do is that the best method to suppress LH is ANTAG. This is not an agonist protocol. It is an ANTAG protocol, the best protocol to suppress LH because it does immediately. And it does a optimal amount of suppression. That's the best part about it. The higher dose, more than 300 should not be given to any patient. Even in poor responders. I don't know how much dose you are giving, but the capping is 300 units for any patient. And the use of recombinant FSH vis-a-vis HMG or FSH are all the same, but depending upon which brand you are using. In India, in case you use a local brand made in Shimla or made in Nagpur of HMG, then you feel that foreign paper mein to likha hua tha, they are equal, but they are comparing companies like Ferring or Sun Pharma, they are comparing Merck. So in our countries, the variations can be quite a lot. So be very careful about this statement, though as per the guidelines, they are the same in case you buy from the good brand. We are in habit of tweaking our drug dosages. We start with 75, or then we make 225, make it 300. This should not be done. Not recommended. have a standard dose or bring a difference of around 75 units, not more than. Don't go seesaw. That should not be done. NTAC protocol is the best protocol. NTAC protocol, best protocol, NTAC protocol should be triggered with an agonist. That's the beauty of an NTAC, so that we won't have any ovarian hyperstimulation. Adjuvant therapies. We are very fond of giving multiple drugs here and there to the people. So metformin, not indicated. Until you want to suppress ovarian hyperstimulation. Here metformin is given over a period of around 2 months or 40 days minimum. It can work, but don't give it as a routine to reduce androgens in a cycle. We give it to reduce ovarian hyperstimulation. Sildenafil, not recommended. Not recommended. It doesn't do any magic. Random protocols are not recommended. Random protocols are primarily meant for
Fertility preservation.
my parrots talking. Fantastic. Thank you so much. Great. So aspirin, not indicated. Not indicated. Then some people use growth hormones. We use multiple things, not recommended. So GnRH NTAC protocol is recommended everywhere. And this is important term is that random start protocols are only for fertility preservation. How do we monitor? How do we monitor an IVF cycle? So the best method is that we are doing an ultrasound. Best method. I give you 30 seconds to read that line verbatim from guidelines. E2, progesterone, LH is not recommended. The only way you can do is you can do an ultrasound. I don't say you don't do it, but that should have some indication. Follicle size kya hona chahiye? 17, 18, 19, 20 we don't know. 17, 18, 19, 20 we don't know. But overall they say that around 20 millimeter is in. My size is 20 millimeter. I don't believe in triggering at 17 millimeter because it's good to achieve 20 millimeter size, 20 to 22 millimeter size to have optimal outcome. In case we are not getting, I've seen people in a PCO or a poor responders, dar jate hain. After 10 days, they will stop the cycle. Never stop the cycle. We have to build up a threshold in the body for giving a chronic low dose protocol. So never cancel a cycle. Never cancel a cycle. Until the AFC is very high, sorry, the AMH is very low, she's a poor responder, you can do it. But in a PCO patient, never cancel a cycle. Start low and prolong the window period. They will respond. So just remember that more than 18 follicles are not allowed. They give you a problem. But nowadays we also know that our guidelines, they don't permit us in donors to get more than 7 to 8 eggs. So I'll stop it here only. Triggering ovulation, that to trigger the right method is GnRH. In a GnRH, in an NTAC cycle, the right method is agonist. The best method to trigger is agonist in an NTAC cycle. And in a GnRH agonist cycle, iske andar we really can't do much. Here we are doing the trigger with HCG because they already have agonist, they're already on agonist. So just to conclude, I think I have taken some time of yours. I'm already 18 at within 1 hour. To conclude, for IUI, we carry out ovulation induction. We carry out ovulation induction for IUI. Monofollicular in anovulatory woman. But when we talk about, so letrozole is the drug of choice here. But when we talk about CUH or SO, here we can use hyperstimulation, and here we use gonadotropins, and here we want to have multiple follicular growth. That's the way it works. And here we then later on we can do an IVF, or we can, they've written we can do time intercourse also, but I don't believe in this. I think we should give them a single embryo transfer or a single blast transfer and finish off the cycle. That's the way the controlled ovarian stimulation works. In next curtain raiser, we'll talk about multiple things. How do we do stratification of a particular case? That we'll be talking next month. Thank you so much. It was wonderful being with all of you. And this will be the event which you should always attend. This will cover up all your dilemmas, all your doubts will be covered up. Then we, on great demand, we are having one on 𝐸𝐸 for clinicians and embryologists. Great demand. People want to know about 𝐸𝐸, when to do, not to do, we'll cover that. And then adjuvants in male infertility are again, second time I've been told to do it. We took one on female infertility, but now we're going to talk about male infertility. That's it from my side. And I would like to tell you about our book, which is coming in next 15 days. It is on IVF, one of the biggest books of the world. In fact, the biggest book in the world. 3 volumes. It will be launched in Telangana after 2 weeks. Just wanted to tell you that it's a good book in case you ever want to read this or buy it. Let us know. Thank you so much. I've ended my talk, and now with this, I will stop sharing and say hello to all of you. Non-stop, parrot. Great. How many are awake? How many have slept?
In letrozole cycle.
I'll take only 3 questions. Customarily, we do.
So for letrozole cycle.
Thank you, sir, for this deliberation.
Thank you. Thank you.
So for letrozole cycle,
Yes,
what do you use as a ovulation trigger?
For letrozole cycle, you can use ovulation trigger safely. See, first of all, letrozole cycle means an IUI cycle. Am I right, Dr. Shah?
Right.
In an IUI cycle, we never have an agonist trigger. Because in case you give an agonist trigger to an IUI cycle, this will lead to poor quality endometrium. So for a monofollicular growth, with clomiphene and letrozole, there's no debate at all because we have to give 𝐻CG only. Because once you give letrozole, once you give agonist trigger, then the quality of endometrium is affected. So that's the point. So,
One question.
But you can give
What
both.
is the luteal phase support you give in
Not
letrozole
indicated.
cycle?
Not indicated. No luteal phase support is indicated in an IUI cycle, sir. Not recommended. In case you're giving HMG, it is recommended. Otherwise, the monofollicular growth or 2 follicles, it is not recommended. As per FOXY, we don't recommend it. Not recommended as per the guidelines available internationally. Multifollicular growth, you have to do it.
We can do both trigger HCG plus GnRH agonist.
You can. I'm not denying you can't, but that's not the right way. Why do you want to mix 2 drugs? For IUI, give only HCG. Monofollicular growth, they say in case you get more than 2 follicles, cancel the cycle. 3 follicles, definitely cancel the cycle. So 2 follicles, you will give HCG. 2 follicles won't lead to ovarian hyperstimulation.
So if 3 follicles, we
Good evening,
have
sir.
to cancel the cycle.
Cancel.
Sir, can I ask one question?
𝐻RA guidelines are very clear. Human reproduction. There are 2 articles. After 3, we should cancel. Yes.
After 3.
Yes.
Sir.
More than two, they say we cancel, but we don't cancel. They say.
But or you can convert to IVF cycle.
No.
This I don't know, ma'am. This I don't know because you'll have a premature LH church coming. How much will it work?
Sir, one question, sir.
Sir, one question, sir.
Only 2 questions. 2 questions. My time is up. Yes.
Sir, sir, you said LH is inversely proportional to the OMI. This part was not clear to me, sir. Sir, will you please?
So do one thing. You talk to me. I've already covered this. What you can do is you can take access to my calendar appointment and you can talk to me.
Yeah. Okay.
My calendar appointment is twice a week, Tuesday, Thursdays, for 10 minutes each from morning 6 to 7 o'clock. You can book an appointment. Then I'll explain to you everything. I'll tell you how it works.
Sir, one question. Dual trigger. Sir, you have said OCP should not be used in the pre-treatment of IVF cycles. So can we use only progesterones like dydrogesterone or something?
They are not indicated. They are not indicated. What do you want to use? They are not. They don't do any magic as such. So they can lead to reduced efficacy. So whatever you use is going to lead to down regulation. They will lead to down regulation. And we want to be as near the natural cycle.
Sir, do they help in synchronous development, synchronization, sir?
They may, but they reduce the efficacy of the cycle. So
some patients have day 2 early recruitment. So to prevent that.
You can use them when you're having a problem of this nature, or use them when you're going in for an batch IVF. but as a routine, they are not recommended. See,
So
we do multiple things. We do multiple things, but they are not recommended.
So what do you suggest? Pre-stimulation
Suppose if
estrogen or pre-stimulation progesterone? What do you prefer in patients with early recruitment, sir? And what is the washout period?
There is no purpose of doing day 2 P4. Only 2 indications are there. Day 2 P4. Only 2 indications. In a case of endometriosis and a PCO patient who are being down-regulated for FET. Endometriosis, do it. Because endometriosis isn't down-regulated. For an FET cycle, do it. PCO patient, FET cycle, down-regulated. Routine.
So pre-stimulation in patients with early recruitment day 2, if we give progesterone or estrogen, what do you suggest? What do you prefer? And what is a washout period for both?
No, that is right. But what type of cycle you are doing here? What type of cycle you're doing here? And what do you mean by recruitment?
What I mean, if we do a day 2 scan and we see few follicles, 1 or 2 follicle of 8 to 9, rest are around 5 to 6.
You're allowed 8
It's not
to 9.
an ideal situation to start.
8 to 9 you're allowed. 8 to 9 you're allowed. The range of the follicles are early antral follicles. 2 to 9 millimeter you can recruit.
No, sir. Suppose we have only 1 or 2 follicle, which is just 9 and rest all are 4 to 5, quite asynchronous.
It's okay. It's not asynchronous. In case you have any follicle size between,
we might end up in monofollicular growth.
No, नहीं होता.
So
if patient, एक चीज याद रखो, 2 to 9 पे शुरू करो. Last question है, इसके बाद I'm signing off.
So if patient,
let me close the last question. Very important question here.
Yes.
2 to 9 millimeter पे asynchronous नहीं होगा नंबर, नहीं होगा. और अगर कभी आपको ऐसा लगता है कि asynchronous हो गया है एक follicle and other follicles are growing, now you got 2 follicles at 22 and 10 follicles at 17 or 16, then you sacrifice those 2 follicles and continue with the stimulation.
Okay, so another school of thought says you can give 3 days of antac before starting. That I've done in few cases.
We do it in nearly every case in which we are doing fertility preservation. All breast cancer patients, I'm just giving antac. That is not a problem, but that's not an ideal situation, ma'am. For every breast cancer patient who comes to me, I just put her on random protocol. Karna aate hi, I'll give them BD, I'll give them antac and start their cycle after 3 days. That is not the right protocol. You want to do it, you can do it, but that's not the right protocol.
So at times we get E2 of 70, 80, more than 80 to 90, and patient desperately wants to start because she has traveled long way. That way is probably we can give antac.
No, she's a poor responder. Ma'am, she's a poor responder. 90 means that she's going into ovarian failure. So build up her and build her reserve. Give her more of ovaries plus or something. Build her up. Give her nutrition. Build her up follicular recruitment capacity. 80 पे तो कभी शुरू करना ही नहीं चाहिए. 80 means she's an ovarian failure. Going into ovarian failure. She's premature ovarian insufficiency. But there are a lot to be covered like this. I'll take these queries in the
one
next.
last question, sir.
No, I can't. No, I can't take. I'm so sorry. I promised a lot of people they complained to me. Then, sir, you are wasting our time. My limit is 9:30. It's already 9:30. I can't take you away from your dinner, from your children. We'll keep meeting. Any doubts, just put in the group, and we will revert back to you. And we'll respond by tomorrow morning. We'll send you all the articles which are required for you. I think I'll stop here.
Sir, it's not a question. I just need to know. So you will be teaching us about the different protocols also. So we are for the course 3. Like these are.
Yeah. Relax. Chinta nahi karo.
Okay.
Chinta nahi.
Okay.
This is not part of our curriculum. This lecture is not part of our curriculum. Whatever I teach here, it's not meant for alumnus at all. It's an open lecture. Alumnus has got special lectures. Okay. Bye then. Bye guys.
How can we get access to
Bye.
Thank you, sir.
Bye, sir. Thank you.
Bye.
Bye, sir. Thank you. Bye.
Good night, sir.
Thank you.
Bye, sir. Thank you.
Bye.
Good night.
Thank you.
बस हो गया.
Thank you.